we can make life a lot better for people.
Saying he doesn't know what I have, but he's saying I'm going to be like this the rest of my life. It was very, I was like, no, I'm not giving up, but isn't it hard for patients, wouldn't you say, to keep going once they keep hearing these things?
Just for the people watching, whether it's a caregiver, a potential porphyria patient, or maybe even a physician, I mean, what would you tell them in regard to porphyria broadly?
Well, I would tell them that it doesn't need to own you.
Welcome to Rarely Discussed, an American Porphyria Foundation podcast with your hosts, Andrew McManamon
and Nicole Castellano.
We have porphyria, a rare disease. Rare diseases differ greatly but share many similarities in how they affect our lives.
Being rare can feel lonely and isolating, but we're stronger together. Join us in meaningful interviews with porphyria and rare disease experts and the patients and families impacted as we connect, learn, and heal together.
We'll talk diagnosis, treatment, pain, mental health, managing daily life, and everything rare. Welcome to Rarely Discussed. This is episode number 7, and we have a very, very special guest on today. And I thought, Nicole, you could take the reins and introduce this important guest we have.
Yes, today we have Dr. Roy E. Smith. He is a hematologist at the University of Pittsburgh Medical Center. He's a porphyria expert, and he is also on the scientific advisory board of the American Porphyria Foundation, and he is very active. He does a lot of educational Zooms for patients. He's also, what we hear from patients, is a patient favorite. So because he takes the time to listen to everybody and answer all their questions and never rush and everything. And he's so competent. So Dr. Smith, thank you so much for being here today.
You're welcome.
I thought we could just start off, if you want to tell us a little bit about yourself, where you practice, what you do, that type of thing.
Well, I'm obviously I'm in Pittsburgh, Pennsylvania. I'm at the University of Pittsburgh Medical Center. I'm a professor of medicine. I'm board certified in internal medicine, uh, uh, hematology, and medical oncology. And my interest for many years has been rare bleeding disorders and thrombotic disorders in patients. And that interest has led me to seeing people with other rare disorders. So I am establishing a rare hematologic disorders program here at at the University of Pittsburgh, and through that rare disorders program, I began to see uh, patients with porphyria, and that's how I developed my interest in it. What I found was that there was nobody in our center or even in our region that alleged to have expertise in the treatment of porphyria. And as I began to see patients, I realized that that is absolutely true. that there are very few people that know anything about this disease, and uh, and as I try to develop interest by other disciplines in medicine in our own organization to see patients with porphyria, uh, others had no deep interest in it. So for that reason, I began to do this myself and began to collect porphyria patients in my own practice. It's been very rewarding for me, and my interest in porphyria has increased markedly. And right now in my division in the Department of Medicine here at the University of Pittsburgh Medical Center, I'm really the only person that sees porphyria patients.
Wow.
Now there are porphyria patients that aren't seen in our center because of insurance issues and things like that. However, well, as far as I know, everybody that sees a porphyria patient in this area contacts me to discuss their case with me. So some of the cases I don't actually see personally, or I may see them for one occasion only, and then I send them back to where they came from. But that's the way modern medicine is these days, I think, with insurance issues and restrictions on where patients can go and be seen.
So go ahead, Nicole.
No, go ahead.
I was just going to ask because I mean, you mentioned how not a lot of doctors and things like that weren't interested in porphyria, but what really got you interested in that? I know you have a background, obviously, in hematology, blood disorders, and things like that, but what really
Yeah,
drove?
so one of the things that got me interested in the type of hematology that I practice is that there's a easy logic to people that have bleeding disorders and thrombotic disorders, and that easy logic, in terms of the natural history of the disease and the pathogenesis of the disease, also applies to people that have porphyria. I don't find this a difficult thing to, disease to take care of. I don't find it difficult to diagnose myself, but I do understand, as with people that have bleeding disorders, it's an unusual unusual problem, and a lot of other physicians and uh, medical people, have heard the terminology. They've never seen a case. They don't really know how to evaluate it. They don't know how to interpret the results when they come back, that sort of thing. And I kind of like that. I really get into this stuff and learn it in great detail. So I've spent a lot of time, and I do mean a lot of time, uh, delving into the literature about porphyria. And as a consequence to that, with the exception of the rare ALAD deficiency, porphyria, I, I, I've seen them all.
Wow. What kind of compelled you to dive in like that? Was it just something about the disease that was interesting, or was it the patients, or just because you had already been really interested in rare diseases, or you're just good at it?
No, I'll tell you, I think it was, to be frank about it, I think it was the suffering that I was seeing from porphyria patients, and this sounds trite, but it's the truth. And that is that, I'm here to relieve suffering. And, and when I see patients come in, and when I'm called to the emergency room, and some young girl has been there 5 times, and they've had their gallbladder taken out, their spleen removed, and have had exploratory laparotomies done when they're 24 years old,
Right.
uh, I get really upset about it. And that's kind of the typical story of a person with acute hepatic porphyria. And it's a disease that, I don't want to say it's easy to treat. I don't think that's correct, but it's a disease that's treatable. And many of the people that I've picked up with porphyria over the years have been people that have been dealing with this for years and years and years, uh, and with no diagnosis, no rational intervention. And it's largely because the people that they have seen in the past either don't think about it, or they don't know how to diagnose it. And so it's a disease that I think, uh, in the appropriate hands, people can be taken care of very nicely, and patients can be very comfortable with this, and they don't have to face the complications that are associated with it.
Yeah. Just to speak to you just said about it's typical, and I know for my experience, I was in and out of that 9 abdominal surgeries, a hysterectomy I didn't need. It was over 12 years of suffering. Is there? Can you just speak to what can happen to patients when they do go for a long period of time without getting diagnosed, like what the consequences are with possibly chronic symptoms later, or nerve damage down the road, or anything like that?
Sure, of course, it depends on the type of porphyria that you have. So, speaking about acute hepatic porphyria, or which the most common type is acute intermittent porphyria. Uh, Patients have recurrent painful attacks. They often have electrolyte abnormalities that can be life-threatening. I have a patient I see here that has had multiple seizures. Uh, they can become paralyzed. I was down in Brazil last year, and there they have a founders of a genetic effect, and they have a lot of porphyria patients, but no rational way to treat them because of the limitations that they have. And they see a lot of paralysis, even death, from porphyria. So it can be, the consequences can be extreme. Uh, You can develop a peripheral neuropathy from it that can be chronic. I've seen people who have had chronic peripheral neuropathy, no diabetes, no other cause of it, and they end up having porphyria, and that can be prevented with appropriate therapy. Obviously, if you have acute hepatic porphyria, you do have an increased risk of developing hepatocellular carcinoma at a later date. Uh, and uh, I have a patient that I don't see at the moment, but I've seen in the past who was diagnosed after many. I'm talking, 60 years,
Oh my God.
and uh, she had recurrent hallucinations and delusions, and I am virtually certain it was from a porphyria
Yeah.
and chronic pain pattern, completely atypical pain pattern. Uh, not the usual thing that you think about that's acute abdominal pain. This person had pain in their back and their shoulders and was told she had fibromyalgia and different, various things. And once started on therapy, it all went away, So uh, the disease can be severe and life threatening. And surely no one wants to go through that, and I certainly don't want to, have people go through that. And people that have, the more cutaneous oriented porphyrias like PCT, porphyria cutanea tarda, or EPP, erythropoietic protoporphyria, uh, uh, the EPPs are probably the patients that I love to see the most because they come in and they tell me, they can't take their child out to the beach. They can't ride a bicycle. They they have to live with wearing veils and big hats and dark clothes, and they can't drive a car without their hands, getting all burnt and painful and stuff. And once I make a diagnosis and I put them on therapy, the therapy is so effective that I've literally never had a patient with EPP that hasn't had a gratifying response where they've been able to return to a normal life.
Is
You
that
know,
is
so
that with Siness that they were able to kind of have a life change like that?
yeah, with afamelanotide, yeah. I mean, that's the only therapy that's rational therapy that's available right now. Anyways, I think I've had some patients that I've put on some you know uh, retinoids and things like that have had some minor improvement, but the real change came with afamelanotide, and my goodness, some of the I've had almost invariably, even men I have come back to me, and they're almost in, well, not almost, they literally cry
Wow.
because for the first time they're able to go to a baseball game with their son, or do something with their daughter or something. Uh, and I had one person down and who doesn't see me anymore. She found a doctor closer to home, but she was from she was a retired college person, administrator, who was down in, I think she was in San Antonio, and she got married, and her husband he lived on a ranch, and she was unable to leave the ranch house.
Wow.
and and she got one dose of afamelanotide, came back, and said she didn't have to wear a hat. She could go out and handle the cows and cattle and stuff with her husband, and do all that kind of stuff around the ranch. And
I got
it was
chills.
it was like a brand new world for her. So I think that's, yeah, I'm not here advertising afamelanotide. I'm just saying it's a treatable disease, and you, you know uh, people suffer terribly from it. And it may not look like that to a person who does not have the disease, because there's no permanent changes that occur in the skin. But my goodness, these people's, I just met a guy just about 3 weeks ago whose mother has EPP. He has it. She finally talked him to coming in. He's a young man. He lives alone. He keeps his room dark. He has shades on his windows. He only goes out at night. Uh, he doesn't have a job, uh, and doesn't have a girlfriend. Basically sounds like he has no friends whatsoever. Uh, and can you imagine going through life like that? I
No.
mean, that's just
No,
how miserable can you be?
the isolation and is with all the porphyrias, but especially with patients that we talk to all the time that they do have to stay inside, or they can't get on treatment, or they can't find a doctor, they haven't gotten a diagnosis yet, and even the head of the Canadian Porphyria Association was saying, I didn't even think about it. When she's driving a car, she has to think about, where to sit and everything like that. And George, that we had on, who has EPP, he was like planning a road trip. He's like, we got to plan which direction we're going when the sun comes up and goes down. And it sounds like for people that do venture out, even if they do have, they have bad consequences of pain, it seems it's just very, it's exhausting. I think a lot of things about this disease are exhausting, but specific.
Yeah, I mean, that's something, it's what's really interesting. When I first got interested in porphyria seriously, I, I thought to myself, well, where are these people going to present? They're going to present in gastroenterology because of abdominal pain or the emergency room, and they're going to present to dermatologists because of the blistering and the sensitivity to the sun and stuff. And it's very interesting because I went over and talked to our gastroenterologist, and what they told me is they hadn't seen a case of acute hepatic porphyria in 30 years. They stopped looking for it. I went to our emergency room, and this is a big university here. This is, we're a coronary care center. I see people from all over the world, and so this is not a small hospital here. And I went to our emergency room, and I said, well, how often do you send samples off for porphyria? Never, never. and I talked to our dermatologist, and I said, well, I said, if you see anybody with EPP, and you don't really want to take care of them, I'm happy to see these patients. They never look for it, never see it, and that was quite a few years ago. Things are a little bit different now, but I think it's different. I mean, this sounds arrogant. I don't mean it this way, but I think it's a little different because of me, because I have educated people about this disease as much as I can. I've talked to every doctor I can think of, uh, and I've gone and given lectures to different physician groups and stuff like that. So I think people are much more sensitive to it now than they were before. In fact, I know they are because now I'm getting a lot more referrals than I did initially from doctors who originally told me that they never see the disease. And the other thing is that there's a misunderstanding about people that have EPP as an example, because a lot of patients come and tell me that they go to their family practitioner, their PA, or somebody, and the conclusion is that they have sun sensitivity, and they just too much sun, they're getting sun.
Allergy, we hear sometimes
Yeah,
they say
yeah, sun
allergy.
allergy. Yeah, exactly. But they don't take into account that these people go to bed for 2 weeks after they're exposed to the sun, or they can't go to work. You know, I mean, it's a systemic disorder, for God's sakes.
Mhm.
And they're generally completely unaware of the chronic complications that can be associated with UPP. So, so in people that have CEP, which congenital erythropoietic protoporphyria, which is, as you know, is pretty rare. I haven't seen that many of them, but that's a disease that really does require somebody with expertise, true expertise in the treatment of porphyria to take care of those patients. They can get really, really, really sick and have really major complications that that can be quite complex. And you know, we see people with CEP here, although they come long distances. In fact, most of the patients that I see travel 2 to 3 hours to see me, and as a consequence of that, a lot of them I see 2 or 3 times, and enough to get them stable, tell the other docs what to do, and then I hear about them, a year later or something like that. So
So I think as you know, we do a National Porphyria Awareness Week. The APF does, and we have a slogan. And one of this year that we did was "Think Porphyria." And we've kind of decided we're probably going to just keep doing that because I don't know if you agree with this, but I think for doctors that aren't someone like you that think about it and think to test for it, just getting that message out there to just, if you just think about it, especially like you said, if you have someone presenting in the ER over and over and they're tested and nothing's showing up, that this abdominal pain or other things, to just think about it and and to test. And I feel like the APF has done a lot of awareness as well. And I think that it's interesting that you said you've gone to your to people that you work with and the gastroenterologist and the dermatologist, and seeing if you can get referrals and asking about it. Just asking them, it was something, a very small act on your part, but it's now created how many patients are now going to possibly be helped now that you've said that. You've already seen a very large uptake in that, or not large, but it's picked up since doctors are thinking about testing for it. um and then you also were saying how much research you had to do and everything, or that you've read a lot about it. Do you think that's one of the things about rare disease with doctors, why it's hard to kind of get into that? Because you're busy, you have your practice, you're doing things. It sounds like there's a lot of extra work kind of included in treating a rare disease patient. Do they have extra needs like multidisciplinary care? Is it harder to coordinate, like that type of thing?
yeah, so it's interesting you should bring this up because even in my own division, I mean, so I'm in a division of benign hematology at this point, even though I'm also trained as an oncologist. And in my own division, I'm the only one that knows really anything about this disease. And I think I think it's part of this is uh, rarity of the disease. The feeling that you're never going to see a case anyways. And that's what I keep hearing over and over again. But the other thing is that there's this feeling is I'm never going to see a case. Why would I put all this work in? I'm going to forget it anyways. You know, the third thing is I think in these sort of disorders is that uh, many doctors don't feel confident about making the diagnosis. They sort of know the words, but they don't know the subtleties of how you make a diagnosis. Even though it's not the diagnosis of porphyria is not a difficult diagnosis in reality, but you do have to know some subtleties about when to look and how to look and what to order and stuff like that. And probably the biggest thing that I see, besides people just not thinking about it, is when they think about it, they almost invariably get the wrong test.
Mm.
I mean, this is so common, uh, and when they get the results back, they don't know how to interpret it. So they send some specimen off to some lab someplace, and they call up the medical director of the lab or the pathologist of the lab, who basically knows nothing about how it was done or what technician ran it that day or what the runs were like, you know, and and then they have somebody on the other end who theoretically knows something about the disease but doesn't take care of patients, telling them what the diagnosis is, and it just really gets screwed up all the time, and uh, most of the patients I see that are sent to me with with the diagnosis of porphyria actually don't have it. They have something else, but the suspicion is there, and I'm happy to see them because they might have it.
Hmm.
and
Right.
and and you almost invariably they come to see me, and you know the doc got the wrong urine samples, or they sent them to some lab that isn't, in my view, is not reliable, or do it in a way that I wouldn't approve of. And uh, so I think the other thing is that there there's so many subtleties with the diagnosis of this disorder, that if you suspect somebody has porphyria, I think you have to look more than once, you know, uh, because you can never be certain, especially in a smaller institution, even my own institution, as far as that goes, whether the specimens were handled appropriately or not.
Hmm.
Now, I'm lucky because in my own institution, we have our own person that works with us. Our lab is just down the hallway, so I can walk down there and talk to my guy and say, "This person may have porphyria. You know how to handle this, right?" And go over it with him. In in most institutions, you can't do that. And the other thing is that medicine has changed so much. So, I'm a little bit older. I know I look like I'm 20, but I'm actually 78. And I'm old enough that I remember when physicians, uh, you know, if you got a blood smear on somebody or got a CBC on somebody, you went to the lab, looked at the blood sample yourself, that sort of thing. Nobody does. Well, I do, but I mean, nobody does this anymore. They don't have time. The labs are located someplace else. They don't have a lab in their office. They can't afford it. The federal law regulations make it very hard to do that. Uh, so you have medical care that is fragmented at all levels. And part of that fragmentation is due to the fact that there is this overwhelming demand anymore to see as many patients as you can, because every hospital system in the country, as far as I know, is under economic attack. You know, reimbursements are just dropping like crazy. Insurance companies are refusing to pay for things that they used to pay for. Hell, I just had a patient just last week that's on a drug, has been on a drug for 20 years, and the insurance company just declared it's being used experimentally and refuses to pay for it. You stand there and say, "This is nuts. This is craziness." But all that adds to the burden of taking care of patients. And when someone gets a complex case, you stand there and say, "Do I even have the time to do this?" So then you send them off to someone else, and that's where the
Hmm.
fragmentation comes. And then there's this new issue with many hospital systems are now, they don't admit this, but it's what's happening. And that is, in order to save cost, what they're converting to is basically a PA based, physician assistant based system, where some physician is going to supervise, five or six PAs, and the PAs are going to see the patients. And if their patient's really tough, maybe the doctor will see them. Or if the patient demands it, maybe the doctor will see them. I just had this discussion several months ago here, with our department chair, and she pointed this out to me. That's what their plans are here in the future. And I said, but you have to understand, if you're supervising five or six PAs, you're not really supervising anybody,
Right.
because you're not going to be paying that much attention. And the other side of the coin is, somebody that's undertrained doesn't know what they don't know. So all that is happening all at the same time. And I think that is, a pot that's boiling, that allows people to sort of slip through the cracks when they have rare disorders. And and Somebody with a rare disorder can go to one doc, a neurologist as an example, and he stands there and says, well, I don't know why you have peripheral neuropathy. You probably have diabetes. It's waiting to declare itself. Uh, then you go to, a gastroenterologist because you have GERD or something like that.
Mm,
And no one ever thinks about porphyria, you know, as causing GERD, which it can, you know, or they have chronic constipation. Porphyria can cause that. Nobody thinks about it, you know, on and
You're
on. You just go from
describing what
one.
my journey in the beginning, just doing that. And one
right.
neurologist even told me I failed the tilt table test, and there were all these abnormalities, and he didn't know why. And he told my mom, he's like, "You have to just accept your daughter's going to be like this for the rest of her life." And I, I wasn't in attack. I wasn't feeling well. Even at that point where I was very foggy, I was like, "He doesn't even know what." He's saying he doesn't know what I have, but he's saying I'm going to be like this the rest of my life. It was very. I was like, no, I'm not giving up, But isn't it hard for patients? Wouldn't you say to keep going once they keep hearing these things and just say, okay, maybe I'll wait for the diabetes to manifest, or maybe I'll.
Yeah, it is. It's very difficult. I think the other side of the coin is, because of the influence of the internet. Like I said, most of the patients I see that are referred to me or come to me spontaneously don't have porphyria. And there are two diseases on the internet that are people come in and they have self-diagnosed themselves with. Uh, they almost invariably don't have it, but you know you have to deal with it. And one of them is porphyria. The other one is mast cell activation syndrome. And when people come and they self-diagnose themselves, and these are generally people that are very desperate. The reason they're on the internet is because no one can tell them what's wrong with them. They're desperate, and but they've concluded based upon something they've read on the internet they have porphyria. And one of the difficulties here is when they don't have porphyria, is they won't give it up. They just will not give it up. And and you run into this situation where people begin to own the disease. Those dumb doctors, they don't know what they're talking about. Uh, I have porphyria. I know I have porphyria, and but there's no evidence of it. And that makes things much more complex. And it takes those family practitioners and general internists and general surgeons who deal with these people before they get to me, and it discourages them from seeing people with those kinds of complaints because
Hmm.
it just takes so much time, and people are so dissatisfied, you know. So it's kind of a double-edged sword,
Right.
with a rare disease like this, which presents with, a multiplex presentation, where uh, which can confuse everybody. It gets to be complex and long, drawn out sort of thing that virtually everybody gets discouraged about.
I wanted to circle back to those subtleties a little bit because at the beginning, I know you said porphyria is easily diagnosed. I know there's probably people that be watching like, what do you mean? I mean, these doctors don't even we're going to don't know what they're talking about. The diagnosis time's 15 years on average. So I wanted to ask you, I mean, what are you looking for when somebody comes in? What are the symptoms? What are the tests that you're putting forth for them?
Well, the first thing I do is I've taught myself to recognize the fact that porphyria has many different presentations, especially acute hepatic porphyria, many different presentations. Now, it's absolutely true in the medical literature that 80-95% of people with acute hepatic porphyria present with abdominal pain. And uh, but that's actually has not been my experience, to be honest with you.
Hmm,
Uh, Everybody has abdominal pain at some point. That's true. Okay, and I think that part of it is true. I think 90% of people have abdominal pain, but they don't always present at the ER or at your office with abdominal pain.
right.
In fact, in females, usually what I hear is brain fog. You know, I can't think. I can't balance my checkbook. I can't take care of my baby. Uh, uh, my husband gets discouraged because I keep forgetting things. Or someone that comes in with peripheral neuropathy. That sort of thing. Uh, 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 Remember that at least with AIP and presumably also with the other types of acute hepatic porphyrias, it's likely that 90% or so of people have, one acute attack of abdominal pain in a lifetime. That's probably true. You know, so how else do they present? They present with shoulder pain, back pain. My personal experience is usually back pain, uh, uh, peripheral neuropathy, numbness.
I have this 24/7, 365 chronic pain. I think probably because I went so long without getting treated. But yeah, it's that's more now why I have to go get treatment. Instead, I do have abdominal pain, but it's gotten much better over the years, and it's usually for I can't stand the pain anymore, so I have to get treatment.
Yeah, yeah, yeah. So, so the first thing I do is when these people come in with these unusual presentations, automatically they get checked for porphyria. Automatically, it's a routine thing for me, and I think it should be a routine thing in the emergency room for people that come in with pelvic pain, abdominal pain, or any other unexplained pain. To tell you the
Right.
truth, so so. Uh, so when I say it's easy to make the diagnosis, it's easy after you after you think about it,
Hmm.
But you have to think about it first. And and in terms of how other ways that people present, many of the older women that I have seen with porphyria, these are generally people that have been diagnosed with fibromyalgia, or they have some sort of, oh, I have arthritis,
What about chronic fatigue
Well, what
syndrome?
do
Do you
you
hear that at all?
Yes, yes, absolutely, yeah, 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 or long COVID, and now it's long COVID, uh, but yeah, those things I hear all the time, and and most of the people that I see with acute hepatic porphyria, complain about fatigue. In fact, I was on the phone just this morning with a patient that I've been seeing for a long time. She's an employee here, has acute hepatic porphyria, presented with seizures. She's what? She's 39 years old. Presented with seizures while pregnant when hyponatremic. Uh, Developed severe peripheral neuropathy. Became partially paralyzed. You know, uh, was looked like she was developing Guillain-Barré from it, something similar to Guillain-Barré, semi-paralysis. Didn't actually develop the full thing. And she called me up last week. Uh, she had a case of COVID and was had gotten over it, but now she had nausea and vomiting and back pain. Then she developed abdominal pain. So here's a person that presented with abdominal pain, uh, and we put her on Hematin, and she got 4 doses of it as an outpatient. She's back to work and able to take care of her 3 babies, and she's doing fine. She's a person that I've taught to understand what the prodrome is with porphyria. And she was right on top of it. Called me up, doctor, I think I have an attack. And she was right.
So I guess with that in mind too is just I know you're a well-oiled machine over there when it comes to porphyria now, but is there a particular case or patient where you're struggling a little bit with, or if you're on the fence with on
Yes,
how to
yes,
deal?
more than one. As a matter of fact, one of the things that really concerns me a great deal is, when we make the diagnosis of acute hepatic porphyria, at least when people come to see me, I do the full workup for porphyria. Uh, Rather than just screening, because people have to travel so far, and I don't want them to run back and forth. And by the way, if they get these labs drawn at some other site, I don't know what lab they're going to, what reference lab they're going to go to. I use only one because it's reliable, and I can call the physician that runs the lab and discuss with him what the runs were that day, what technician ran them, what strange things happened in the lab, et cetera, et cetera. So I use only one laboratory, and uh, yeah, and I do the full workup. Everybody comes to see me if they have acute hepatic porphyria. I have all the necessary samples sent from all the different sites that it's collected from. Uh, so I'm very thorough. Uh, but the fact of the matter is that the ask me your question again.
Just if you, I know your process is is really good when it comes to diagnosing porphyria, but I wanted to ask if there was any troublesome patients that
Oh
you were
yes,
dealing
yes.
with.
Thank you. Because I lost my train of thought there. But the the problem is that when you send these samples off and you get a porphyrin level back in the urine, that's you know minimally elevated. Okay, so most of us use a standard that would say that your porphyrin need to be maybe 5 or 10 times, at least 5 times greater than normal, uh, the upper limit of normal. But I see a fair number of people where the porphyrin are either are between 0 and 5 and a fivefold increase. And these are almost always people that come in convinced that they have porphyria, and I don't know what to do with those people. Okay, because if you do a DNA analysis on them, and I do that pretty much on everybody that I think really has the disease. Uh, the DNA analysis itself doesn't tell you whether you have the disease or not. It just tells you that you have the genetic defect. And you don't want to label a person with porphyria if they don't have it, because many of these people, especially older women, I sound like I'm a chauvinist here. I don't mean it that way, but especially older women begin to own that diagnosis, whether they have it or not. And it controls their lives. And you don't want to have someone walking around thinking they have some chronic disease that they don't have. Uh, and So that's a real dilemma. How do you make that diagnosis in that setting? And there is no consensus about this. So for those individuals, I tend to have them come back multiple times to have these things done. And the other thing is, especially if they have these things done and they bring the results with them from some outside laboratory someplace, I have absolutely no idea what the quality of those samples are.
Hmm.
Were they protected from the light? Were they put in a refrigerator? Were they shipped from here to Chantilly in California or Virginia or someplace and left on the back of the FedEx truck for 3 days before it got there? I have no
Right.
way of knowing that. You know, so I think those people are a dilemma.
Yeah. Well, as far as you mentioned genetic testing, um, I actually just spoke with the doctor last week, and she had said with the I don't know if you're do you use the Invitae test with it does the 10 genes?
Yeah.
She was saying that, and I
Mhm.
was shocked. I know that it's really really accurate. I've heard it's 97% accurate, which is pretty great. She had said that when she's had the kit sent to the home and they spit in the tube, and she doesn't do the buccal swab or the blood herself, they've come back
Mhm.
negative. But then when she does it herself again, it comes back positive. And it had never, I hadn't heard that before. And have you heard that, or does that sound?
I've never, I've never seen it, but it does make sense. If you're producing a sputum sample, it's the quality of the sputum sample that, I mean, if it's positive, it's positive. If it's negative and positive, it's positive. So that sounds to me like it's just a sampling error, and that's what I mean. That's what I'm talking about. Is
Right.
my goodness gracious? Can you imagine going to some 200-bed hospital or 100-bed hospital in some small town someplace and saying you want to collect a urine sample to send off to this lab that no one knows where it is, and some technician that is there part time, because that's literally the way it is often. After 5 o'clock, they have some high school graduate who's spent some time in some technical school someplace for a year or two, who, you know, mostly just plates urine specimens for cultures, and you walk in and say, I think I have porphyria. My doctor wants me to have this. And that person doesn't have the slightest idea what the hell you're even talking about, let
Mhm.
alone how to handle the specimen or where to send it. So it's going to sit someplace until the next day, until the real people come in, to figure out where to send it and how to handle it. By that time, it's probably
Wow.
too late.
Yeah, because a lot of patients complain of that they feel their samples have been mishandled, that it was exposed to the light. They didn't
Mhm.
know. I mean, I guess what would you say? So the APF, we really focus on right now. Educating just GPs, PAs, things like that can at least think about it. Order the proper test. We give the doctor packet that has which screening test to order. The treatment options.
Mhm.
Just everything that they may need. The labs that are generally used, if so they can feel, because like you said, a lot of times they don't feel confident because they haven't done it before, and we always say, don't worry, Dr. Smith can help you. I know, I'm sure you're sick of all the emails, but you're so great about helping all these other doctors and patients. But what would be the best case scenario for someone in maybe a rural or a small hospital setting where they don't have someone like you down the hall that tells them exactly how to do it? What's the best way for them to get the biggest chance of having an accurate results?
Well, I think the best chance is to go someplace that knows how to handle it, some larger institution. Uh, but if that's not there, then the best chance to get a good result, I think, is really just providing a random urine sample, rather than some large collection. My own experience, not just with porphyria, but other disorders that I have to collect 24-hour urines on, are that invariably everybody loses a sample, and it's not reliable for that reason. Uh, the other thing I think, what's been published so far is that there doesn't seem to be uh, uh, any major drawback to using a spot urine sample. So that makes it easier. Uh, I think the other thing is, if I was the patient, I was going to some small hospital someplace, I would stand there and you know tell the person who gets the sample, put it in, cover it with tin foil or something like that, and put it in a refrigerator. I would tell them to do that, and I've had to do that here when on occasion patients come to my own institution, but not to where I am, but some other part of the institution where there's the general laboratory. Uh, uh, I've had patients come and tell me that they watched the person who collected their urine sample stand there and set it on the desk, in front of a gigantic light. And they've gone off to get X-rays and came back, walked by the same desk, and is still sitting there, in light at room temperature. That's at my own institution. That's why I have people come to where I am located, and I have my own person that does this stuff for me. And so I think that's a real problem, and it's a problem, everywhere. And so that's what I would tell patients. And the other thing is, now I haven't done this for my patients, but I might. Now that I'm thinking about it, I haven't really thought about it before. But what I generally do is, when I see people here in consultation that are going to go back home and be treated once the diagnosis is made, I provide the local physician with what I consider to be a protocol that I would do to treat the patient and to monitor them. I send it to them so that they have it written out for them and stuff, so they don't have to look it up and all that kind of stuff. And what I would say is the smart thing is to do the same thing for the patients. And you know, uh, provide them with some written information, a packet of information about where they should go, how the urine should be handled, that can be made available to the lab technician, who's handling the specimen, you know, and uh, at least that's how I would see a way to solve that problem. But I think realistically, the way to solve the problem is to come someplace where it's going to be reliably taken care of. I think the uh, the other issue I should mention to you is I think the issue of light exposure and temperature exposure is a little exaggerated. You know, uh, these things don't get oxidized in 30 seconds exposure to the sun or light. So most of the data that I've read about this, and there was just a recent paper from Wales. A friend of mine in Wales who's a pathologist does all the porphyria stuff in Wales. Wrote a paper, and they examined this question in their laboratory, and if I remember the paper correctly, I think they lost 20% of their activity over a 6 to 7 hour period. So a 20% drop probably for most people that truly have porphyria is not going to make any difference in terms of making the diagnosis. It's only in those people that have that in between porphyrin levels and porphyrin levels that would probably make any difference at all, to tell you the truth. Uh, so, but I think when you're looking at these samples, everybody should start at the same place, and the same place would be a fresh sample that's refrigerated and protected from the light, so that there's absolutely no question about it. But when I have people who call me up and tell me, the specimen wasn't handled appropriately, and I call the lab and I say, well, how long has this been sitting there? And it turns out, well, it wasn't handled appropriately and it was sitting on the shelf for a half hour. Yeah, I have them send it anyways, because the overwhelming chance that that's not going to make any difference. Uh, but I can trust the people I talk to here. I'm not sure I can trust a person in some small town someplace. Like a high school student doing
You
the
know,
lab
you
work.
you mentioned about PBG being just a little elevated, and I know, and I don't obviously know nearly as much about this as you do, but that's why I want to ask. So I know with the natural history study that was done, they were saying that if correct me if I'm wrong, that the amount of pain that a patient is having isn't necessarily directly proportional to the elevation of their PBG. Is that the case? And if so, um, what what does that mean then? And you're saying levels have to be 5 to 10 times normal in order to be diagnostic. Um, and you know, how is that if someone's in pain and their PBG is low, and we're saying, well, that's you know that is still probably porphyria. What can you maybe explain? Because I hear this patients ask this sometimes. They're like, well, if it doesn't have to be that high to have tons of pain, then what about when I get my lab result? Because a lot of labs don't have even a normal range for PBG. If they do, they don't come back and say it has to be 3, 5, 10 times normal. So what would you say to that?
Yeah, that's the dilemma I was talking about earlier. Yeah, yeah. I have a patient like that right now, as a matter of fact, that I'm saying PPG levels are minimally elevated, and she has a very unusual presentation that doesn't sound like you know most of the pure patients I see, but she is uh, she has a DNA defect consistent with variegate. And is this an unusual presentation? I don't really know at this point, but she's being treated locally as if she has it. I've arranged for that. So so sometimes what you have to do is treat people and see if they get better, and if they get better, well, that may be what it is. Okay. Now the issue about porphyrin levels and symptoms, in general, if you have symptoms, your porphyrin levels are going to go up. In general, believe me, I have seen exceptions to this, no doubt about it. Okay, the person I'm talking about right now is an exception to that. The person that I was talking about earlier that got hematin just recently, uh, she has chronic elevations in her porphyrin, and I just got her sample back that we sent off prior to starting her latest dose of hematin. I just got it back just before I got on the line here, and her porphyrin are not any greater than they are at her baseline. Okay,
Hmm.
so there's two examples right there. Now the cutoff in the elevation of porphyrin is largely based upon what you would expect to see if a person was one uh, uh, dehydrated, okay, and the porphyrins and porphyrin was being concentrated in the urine, not because of the secretion is elevated, but because the urine is less dilute. Uh, or it's what you would see in a person that has a reason to have porphyrins or porphyrin elevated that is not from porphyria. As an example, a person that has chronic liver disease or gallbladder disease or acute gallbladder disease, as far as that goes, or a viral syndrome or a lymphoma like Hodgkin's disease or non-Hodgkin's lymphoma, they can have elevated porphyrins because of their disease, not because of porphyria. Now, porphyrin, not so much, but it does occur. All right. Uh, so they almost never rise above 5 times the upper limit of normal in any of those settings. So that's what that cutoff's for. Okay. But the dilemma is, what does it mean when you have porphyrin that are less high than that, that are in that gray zone, and people are presenting with pain or peripheral neuropathy? I don't know. And then if you get the DNA analysis and it's positive, does that mean that you have porphyria? I don't know. So what I do is I treat these people as if they have it, and if they get better, I make the assumption they have it. Okay. The problem with that is, again, you may be taking a person and labeling them with a disease that they
When
don't
you're doing
have.
it, you have complete control of the sample. You know every piece of information that you have is accurate, so you can go ahead. If someone, I know a lot of times patients call in and they say, "Oh, my porphyrins are high," and we explain that that can be a myriad of reasons, like some of you just mentioned. So I guess that would be really difficult for someone who doesn't know nearly as much. I mean, you're a porphyria expert, and you're like, "I don't know." I mean, that's I think every patient listening to this is going to be like, "That's the best doctor ever," like admitting they didn't know something, But and I think that's why you're so good. You really take the time to look at everything, but it seems like it'd be very difficult for a doctor who's new to porphyria, who's trying to help locally because maybe someone like you is too far away, and even if they have that hand reaching out to help them through, especially if the case gets complicated, how do they know, like you said in the first place, that if the genetic, what if someone has a negative genetic, but then does it ever happen where they have the PBG that it's 10 times normal and it is diagnostic? Does that ever happen? Because I've talked to some people, but I mean I don't know, I've seen that.
I, I've never seen. I've certainly seen people that have porphyrin that are very minimally abnormal, whose DNA analysis is negative, and they come convinced that they have porphyria. Uh, but the reality of the matter is the mutational evaluations that we do are really very, very complete, and it's really almost impossible to have porphyria, without a genetic defect you can detect. Now there are some acquired forms of porphyria. Yeah, like PCT. That's that. I mean, that's one of the exceptions. Yeah, uh, there are some acquired forms of porphyria other than PCT also, and as an example, in a person that has, I have a patient I follow here every now and then, uh, who has end stage renal disease. She's on dialysis, and she gets terrible blistering all over her hands and face and stuff, and those people generally have a PCT like disorder. Uh, I saw a patient a couple years ago that had a prosthetic valve placed, uh, and developed hemolysis from destruction of the red blood cells across the valve, and she presented with terrible back pain, and and we evaluated her, and it, she had porphyria, and I called up the surgeon and said, well, look, the reality of the matter is this lady has hemolysis, she has porphyria. The only thing you can do is put in a different valve. You have to go back and redo the surgery again. And of course, as you can imagine, the the surgeon was very reluctant to do anything like that. Ended up doing it because the pain was just unbearable for her. Replaced her valve, and it all went away. I mean, so
Hmm.
there are acquired forms of porphyria that can get it. I mean, it's rare, but you can get it. And in people that are on dialysis or have end-stage renal disease, I've seen it with end-stage renal disease also. Uh, they tend to get a mixed porphyria. They get a pattern in their urine that's consistent with, no, I shouldn't say their urine, but their plasma, that's consistent with PCT, but they also get increased porphyrin in their plasma because porphyrin is being excreted by the kidney that doesn't work. And some of them develop back pain or unusual pain patterns. So uh, it can be acquired, and your DNA analysis can be absolutely normal under those circumstances. And like you said, with PCT, I mean, most of them, I actually don't see very much PCT anymore. It's very interesting because if you look at the literature, uh, a lot of the literature still claims that PCT is the, you know, most common type of porphyria you see, and really, in my experience, it's EPP,
Hmm.
and I think it's because hepatitis C is largely being eliminated, and people are being cured when they get their hepatitis C treated.
Hmm. I wanted to ask you too. So you obviously see a ton of porphyria patients, and I was
No, I don't.
curious.
No, actually, I don't. But I do see a fair amount, but not tons.
Not a ton. Let me rephrase that. Not a ton, but you see porphyria patients, and I wanted to pick your brain because obviously they talk to you, they share their experiences with you. Uh, what have you learned from them, or what is the common thing that they're doing to manage porphyria that you've heard?
Well, the EPP patients, almost all of them have learned to adjust their activity to the sun, and that's part of their disease. That's part of the complaint they have is that they just can't expose themselves to the sun. But almost every one of them knows if they go out in the sun for 10 minutes or 15 minutes or whatever the time interval is, they got to get out. Uh, and so that's one thing. Uh, I think in terms of the people that have acute hepatic porphyria, uh, my experience with them is that uh, they tend to be fighting their disease. They they are I don't want to. How can I say this? I don't want to sound pejorative, but they they uh, they they're not willing to accept the fact that at yeah, at random times they may have a presentation of acute hepatic porphyria, and they tend to be either frustrated about it or angry about it, and I don't blame them. It's
Hmm.
and as a consequence of that, they they kind of walk around with resentment about this and fear. Fear that when they're on vacation, they're going to get acute attack. When they're at their son's high school graduation, they're going to get acute, that sort of thing. Uh, and uh, Especially for the younger, and it is mostly women, especially for the younger women, it's that way, and and so I think the disease changes their lives, and in many ways a negative way, and uh, there's suffering with porphyria that is not necessarily related to biochemical change. It's your reaction to what's happening to you, and it can be permanent. People, their personalities can just change, and and I think that's sad. And it's something that ought to be avoided. And I think that you know, finally identifying what the disease really is helps a great deal. I think for those people that have, you know, uh, you know, frequent attacks or are fearful of frequent attacks, it's not unreasonable to treat these people prophylactically in some fashion to prevent these things from occurring. I realize that's probably not the consensus around the world, but it's my consensus, anyways, is what I think. Uh, and I think also that there's a fair number of people that are running around that have had porphyria attacks. They're not very frequent, but they have residual pain due to chronic nerve damage that uh, is not recognized. I had a patient that I took care of some years ago uh, that came here for a liver transplant. She had an AIP. She went back to where she came from, someplace out west. I got a call from her. And she was desperate because she was having pain and couldn't get help for it. And she asked me to call our local hematologist. I did, and he said, "Well, she had a liver transplant. This can't be porphyria and stuff like that." And I said, "Yeah, then maybe not." I said, "But you have to understand that uh, ALA and PBG may cause irreversible neuropathy and neuritis, and people can get chronic pain." And I don't know whether it happened because I never heard from either one of them back again. But you have to recognize that as a possibility. Uh, there was a manuscript that was published, I don't know when, some years ago, by a somebody who was a physical medicine doctor, if I remember correctly, took care of people with fibromyalgia, and that physician began to screen people for porphyria, and that person's experience was 20% of them had
That's a
porphyria,
huge percentage.
and
Hmm.
and they were,
Cool.
yeah, yeah, yeah. And now that may have been an exaggeration. I don't know.
Sure.
I don't know how the tests were done or anything like that. But uh, it tells you that if you look, you're going to find it, yeah, where you don't expect it. And that's my view of this: is a person comes in to see me and they say they have brain fog, porphyria, peripheral neuropathy, porphyria, et cetera, et cetera. My urine changes color immediately,
Yeah.
porphyria.
Hmm.
I'm allergic to the sun
Right.
immediately, and I think that's the way you have to do it. Now, I was in a meeting in London 3 or 4 years ago where I met this guy that runs the lab in Wales, who's over there. There's a very limited number of laboratories that you can even send a specimen to work up porphyria, and he sees about in his laboratory, he sees specimens he sees about half the specimens from all over Great Britain goes to his lab. And so there's another lab that the rest of them goes to, I think. And he was saying that because there's a limited number of labs that are used in Great Britain, they know exactly what the incidence of porphyria is in Great Britain. And he's saying to me that because I was telling him I think it's a underdiagnosed disorder, and he was saying, "No, no way," because all the specimens come to these two major labs, and that may be true in Britain. That's not true in the United States. And the labs in the United States use different techniques, different laboratory techniques to measure both porphobilinogen as well as porphyrins. And the normal ranges vary from one laboratory to another. That's why I use only one lab, you know. And so I don't consider it to be reliable to have someone come to see me that had a specimen sent to, I don't know, Quest Labs or something like that, the first thing I do is I repeat it, at the lab that I use, because I am suspicious of high volume laboratories doing these kinds of tests that are very difficult to
They
do.
probably don't do them that often.
And
So it's even if someone has done it once or twice, they may not be the technician, right, that gets it the next time and it's their first time.
Right.
exactly. And when I've called some of these labs, I've tried, I've used the Mayo Clinic, I've used Quest, I've used ARUP, uh, and I've used Mount Sinai, which is I think is a little bit more reliable, but doesn't do everything. Uh, and and when I've called up to find out, you know, because they all print out a boilerplate, explanation of what all this stuff means, which means nothing, because it's all boilerplate. And so when I've called these people up, and some of these people are my friends, I call up and I say, Ed, tell me about this. You know, what were the circumstances, in the lab? Who ran this? They can't tell you. They're located in California. The specimens are done in Virginia. They can't tell you. You know, that's unacceptable to me. You know, and I think you have to be meticulous like that. That's why I say that even though you don't lose that much of your specimen because it's exposed to light or urine over a short period of time, you still have to be meticulous. That's why I insist that this stuff be put in the refrigerator or and covered as soon as you get it. I insist upon it in our own location because even though I keep track of this stuff, uh, I don't know that that person's going to go see someone else, and they're going to look at that laboratory specimen, and I know, I may know it's sat out in the sun or out in the sunlight for or fluorescent lights for an hour, and I can take that into account. The other guy can't, or the other
Mhm.
woman can't. So for that reason, I think everybody should start at the same baseline, and that is it's covered and it's refrigerated, from get go.
Mhm.
A lot of patients, you were talking, and we see this a lot because we talk to sometimes 20 to 30 patients a day that call. Again, not all of them have porphyria, but you taking ownership of the disease, and like you said, your their patients are desperate because they've gone to every type of doctor, every so many hospitals, different emergency rooms. They've had every test under the sun done, and then finally there's some inkling of something that looks like it might be positive for this, and then they may go see you and say, yeah, well, yeah, your levels aren't high enough, you don't have it, and you said they take ownership. One thing that I was talking to Desiree about recently is I'd like to make a resource for patients in that situation to say, just to give them a next step where to go. What else? If it's not porphyria, what else? What else for those patients? Do you recommend, like, go check this disease or that disease, and maybe if they haven't been tested for it yet, or something like celiac, if I don't know, I'm just making something up, but just saying these are the 3 or 5 diseases it possibly could be. Could you say something like that, even? Or
I don't think so. I think just illness, because of dehydration. Just illness alone would God it cause those things to be elevated. It doesn't. Someone gets a cold or flu. You know, they can be elevated. The concrete diseases that are very common that would do this would be if your porphyrins are elevated, your PPGs are normal, uh, or close to being normal. Then probably the most common thing would be liver disease or gallbladder disease or someone drinking alcohol. You know, uh, uh, lymphomas and things like that. They've been reported, but not common. Uh, you hate to send someone down a path,
Mhm.
based upon laboratory abnormalities that probably don't mean anything. Uh, what I would do is I would repeat them again in a different laboratory and see if the results are similar. That's what I would do. And uh, I think in a person who's older, uh, uh, it might be worth checking their liver function and screening for gallstones. But that would be about it.
I figured that would be a good place to wrap up, but I wanted to ask you real quick is just for the people watching, whether it's a caregiver, a potential porphyria patient, or maybe even a physician, I mean, what would you tell them in regard to porphyria broadly?
Well, I would tell them that it doesn't need to own you. That 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 porphyria is a treatable disorder. We can be very successful treating it, and we can prevent it from recurring. Not 100% of the time, but we can make life a lot better for people. And that porphyria can cause chronic problems later on in life that are important, like hepatocellular carcinoma or you know permanent damage to the nerves. Or and the other thing I would say broadly is porphyria is one of those diseases that if you actually look at what people self-report of what they go through, it's not just a disease of acute abdominal pain,
Hmm.
and that these other less common presentations that people have. I should point out, uh, when I say less common, what is not easy defined in the medical literature is when a person comes in and they have abdominal pain, that's their complaint, abdominal pain, right? That doesn't mean that they don't have back pain or shoulder pain or leg pain at the same time. That doesn't
Right.
mean they don't have a peripheral neuropathy at the same time. That doesn't mean they don't have constipation with dilatation of their GI tract at the same time. So, so I think the percentages that are often quoted in the medical literature are skewed. They're skewed because there's this process called extinction, and that is when a patient has pain, has multiple sources of pain, okay, at different sites. The one they complain about is the one that's the most intense. You do away with the intense pain, and the next one becomes just as intense, you know?
Right.
So, so there's a bias from the patient in reporting the pain patterns. All right. So, so if a person has unexplained pain, then porphyria is part of your differential diagnosis. So porphyria is a mimicker, okay? Uh, and I think what's been reported in the literature, I don't want to say it's not true. It is true. Uh, most people present with abdominal pain. That's their major complaint. But they have these other things too,
Hmm.
and they don't all occur at the same
Well, in
time,
every attack, right? Sometimes,
right? So
it's chest pain, and then sometimes you have nausea and vomiting, you can't stop throwing up, so you have to go to the hospital, or you have gastroparesis, or whatever. You just can be, or all of the above.
exactly, yeah, yeah,
Yeah.
exactly. Or you get these skin lesions, these blistering skin lesions, and you have variegate or HCP, but you don't have the abdominal pain. They don't have to occur at the same time.
Hmm.
So they get diagnosed with PCT or an eruptive light reaction or something like that, when in reality they have acute hepatic porphyria, but no one's looked for it.
Right.
So I don't know. I don't know if that's what you had in mind or not, but that's
Andrew, I know that we're going to
kind
wrap
of
up,
what I
but I
would
want
say.
to ask Dr. Smith one more question. And Dr. Smith, thanks for staying on so long. Um,
Cool.
as far just and you can make this pretty brief if you'd like. But I've been kind of thinking a lot about now that I'm feeling so much better and I'm able to work full time. I'm like every year I can find something else that's kind of getting better and better and better because I learn more about my attack with triggers and things like that. As far as like the future of porphyria treatment, obviously everything that you just talked about is absolutely the most important, getting properly diagnosed and then being treated properly and followed, supervised by a doctor that has knowledge and knows what to do. Um, as far as other things like mental health, the isolation that we kind of talked about with EPP, with all porphyrias, but especially the cutaneous ones where you can't really, you have to only go out at night and things like that, and not having the social support. Um, do you think that in the future we may see more attention um, from the medical field to kind of look at the whole patient and not just say, you right now we're just going to stop this abdominal pain, or we're going to get these blisters cured or whatever, to kind of treat the whole patient? Do you see other patients looking for that type of care, maybe not from you but from another doctor? Or is it something that they can find somewhere else and they're finding it helpful? I mean, just have you heard anything, or what are your thoughts on that?
Well, 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 I'm sure that I'm sure they'd find it helpful. My background being in medical oncology, also. I mean, we do this all the time where we have tumor boards, and we have uh, multiple doctors see the patients at the same time. Multidisciplinary approach is in my view is always the best approach. The problem is that you have to have a volume of patients that allow you to do something like that. That's the problem. Okay, so I have some friends in Boston. That's they have a tremendous number of people they see in Boston, as you know, and they can't do this either. You know, they kind of say they do, in public, but when you actually talk to them, they don't. You know,
Mm.
and I've tried to do this here. I've actually tried to set up a multidisciplinary program for our porphyria patients, and I do have a bit of a deal with our neurovisceral gastroenterology program that we communicate back and forth, and we exchange patients back and forth. I send when people come to me with abdominal pain, they don't have porphyria, they see them and vice versa. Uh, but we don't meet at the same time, same day, and talk to people about people. Uh, I think the way medicine is going, it's going to be harder and harder to do that for low volume diseases because y people just don't have the time to, you know, if you get a patient with a rare disorder and you get three or four docs, in a tumor board discussing that case for an hour, in the presence of the patient or something like that. Number one, you can't charge for that. The institution can't charge for that time. And two, the docs who may have, very little to say about the case have just spent an hour when they could be in their clinic generating more money for the institution. Now, I'm at a University of Pittsburgh Medical Center, but it's run just like a corporation. I'll tell you, this is not like medicine was 30 years ago, where and I'll tell you also, I've been both criticized heavily as well as congratulated heavily for the way I practice medicine because I literally spend as much time as is necessary with a patient, you know, and my colleagues congratulate me for this. The hospital
Yeah, you could have
administration,
seen two patients
not
in
so
that time,
much.
right?
Hmm.
Or collected. Yeah. I see
Yeah,
that.
Uh-huh.
yeah, exactly. And that pressure is everywhere, is absolutely everywhere. And think about this: what's going to happen when patients are coming in with these rare diseases, and they're going to see a PA who, who's some nurse or some medic from the army that spent an extra year or 2 years in
Right.
training. It ain't the same thing.
Hmm.
I think there's, you know, a potential, you know, I don't want to say disaster, but I don't see where this is going to
Yeah.
happen,
It's
you know,
it's
anytime
discouraging to
soon.
hear, because there's already, I feel like there's so much, a rare disease patient, whether it's porphyria or something else, there's so much more burden on the patient to make those connections and everything, because they're if the Orphan Drug Act hadn't come, we wouldn't have a lot of the new treatments we have for being able to get those tax cuts, be able to make money from spending, God knows how many millions of dollars developing a drug, and then only having this small sample of patients. I guess it seems like it's kind of the same thing. And it's just so much. more for the patient when there isn't um, and I mean, obviously, every disease is horrible, but if it's like breast cancer or something that's more common, you have more support groups locally. We create that, but maybe for a patient meeting, sometimes only be like two, three, four people, but it ends up still being amazing because they have that local support. They're learning about the treatments. They talk to a doctor, an expert like you, things like that. So the burden is, I mean, don't you think the burden's higher on the patient with rare disease? Would you agree?
Oh, absolutely, absolutely. That's why Desiree and I had come up with that plan for,
Right.
designating, centers of excellence in porphyria to encourage, this multidisciplinary approach. Uh, I mean, and I still think, you know,
And we
that
need
could
to
be
make, we're
helpful,
gonna
but
make that happen, hopefully. So,
I, yeah, but I think it's going to require changes in reimbursement and, and insurance companies, recognizing, the fact that there's an advantage and, uh, the disease is so rare that I just don't think that's going to happen anytime soon. And even in my own organization, I have a neurologist that I talk to that I said, I need someone who's interested in neurology to see porphyria patients. They, were happy to do it and all that kind of stuff. But when I try to send patients to that neurologist, it's a 5 or 6 month wait for them to be seen, because they're fitting in with everybody else. And the other thing is the trend in medicine now is out there in the world. Uh, uh, it's getting like it is in Ireland or England, I think, and because I used to live in Ireland, and over there, out in the real world, the family practitioners, they were general practitioners back then. They were called general practitioners, but back then they were basically triage doctors. They would take care if you had a snotty nose or something like that. But if you got somebody who was really sick, you were automatically referred into the in the Dublin or some big city someplace. And and that's what's happening in the United States. I think is you've got these big centers like one I'm at, and we see all these really complex cases here. Uh, uh, and but out in the world, uh, these hospitals are dying. I mean, they're just not getting the financial support, and they're getting killed by the onslaught of all these new people that are coming to the country, and
yeah.
and so what are they going to do in order to keep themselves alive? They've got to get rid of these complex cases and send them to
Well,
me,
yeah,
or
exactly.
you know what I mean. And so people are coming from for hours to get here, and I'm going to keep them here for 2 months to go see a neurologist when they can.
Yeah.
It just doesn't work.
Hmm.
Now, New York
Yeah.
City, it might work. I don't know, but
No, that's
not in Pittsburgh.
you brought up so many things. It's it also just, I don't know if you've seen this, but we have a lot of patients calling where they were able to get the panhematin inpatient, and they're having access problems now because of the hospital or some infusion centers now are not wanting to do it, and we work really hard to fix those problems and find solutions. Recordati's great. They're always there. I mean, any time of day, they're
Yeah,
helping patients try to fix those things. But it,
yeah,
it seems like that fits in with exactly what you're saying, that's kind of how things are going. And then you're right, it is a business. I mean, they can't stay open if they you know can't pay their bills to help patients, and things like that. But it's unfortunate.
yeah, yeah. In fact, I have a patient right now like this who is an hour and a half away. It's the one I was telling you was getting glucose infusions. She's getting glucose infusions because they can't give her hematin. She has no transportation to come here. She's taking care of her parents, both who have lethal diseases and are dying. She was abandoned by her husband. She has a child. She lives an hour and a half away. She can't come back and forth. I called her local doc up. They can't give them hematin. The hospital won't even get it for them, apparently. So she's going to get glucose infusions as an outpatient, and that had to be scheduled. you know, and so she's starting them on Monday, and she has she may have variegate porphyria. I don't know. She's got these minimal elevations, PBGs, but she's got symptoms. And I told her, well, we can try the glucose, see if that works. If it works, then I think you're going to have to bite the bullet and come here and get hemathin.
Mhm.
Yeah.
I
That's
don't
gotta
know
be
what
so
else to do.
frustrating for you when you know what to do, and
But that's
but someone doesn't have the ability to get to you where you can help them. That's gotta be very difficult, because everyone can tell if they're watching this or listening to you, you really care, and that's just gotta kill you. That that you can help if they could just get there. It's just all these things out of a lot of the patient's control, out of your control.
yeah, that's right.
Yeah.
And her family doctor is very helpful, very nice person. Wants to do everything, is willing to do anything, but he can't get if he can't get the drug, if the hospital won't bring it in, you know. So it's it's those issues are almost insurmountable unless you're at a really big institution in a really big city, and I know for sure that some of these larger institutions that claim they do this multidisciplinary care really don't. I
Mhm.
mean, they have, they have people available, but they don't have a system where every patient with porphyria comes in and is seen by all the disciplines that they should be seen. I know they don't, and I know we don't here. Because I can't.
Yeah, yeah. We definitely appreciate your time. Appreciate you setting some time aside to chat with us and answer all the questions that I know a lot of people are wanting the answers to. So we definitely appreciate your time today.
All right. Well, I'm happy to do it
Well,
anytime.
thank you,
Call
Dr.
me
Smith.
again.
We
I'm more
appreciate
than
it so
happy to
much.
do
This
it.
is gonna be so helpful for so many.
Thank you for taking the time out of your day to listen to our podcast. If you enjoyed this episode, please share it with friends, family, or anyone who could benefit. And please don't forget to subscribe and leave a review on your preferred platform. It helps us spread awareness, and we would be extremely grateful. You can also follow Rarely Discussed on Instagram, YouTube, as well as TikTok. If you're someone seeking diagnosis for porphyria, visit porphyriafoundation.org to receive a free doctor packet, forms for free DNA testing, and a list of doctors in your area. Stay tuned for more episodes of Rarely Discussed.